Right, so it's really talking about victim empathy and mentally disordered offenders. And just look at, hang on, just doesn't want to move this. Oh. I just tried to move, press that one, the normal one. That's the normal one. It didn't want to move. I'll use that one then. Yeah. Okay, thank you. Okay, and the presentation is really based largely on an article that has recently been accepted for publication. And you can see the list of authors, and Susie is leading on that article. That's going to be published in Psychiatric Research. But I want to talk about empathy in a more general sense before talking about the research that we've been doing into the Vera. Now, if you look at the definitions of empathy, there are many different definitions of empathy, and it's usually considered that it's not a unitary concept. It's actually fact, it's a list of different things. And empathy in the broadest sense, there was an important article by Davis in 1983 talking about empathy, and in the broadest sense, it refers to the reaction of one individual to the experience of another. And Simon Baron-Cohen, in his book, talks about two stages in relation to the definition of empathy. The first is a kind of single-minded attention focus, and empathy occurs when we suspend that single-minded attitude and adopt a more double-minded attention. So in actual fact, rather than just focusing on ourselves, we are able to focus on someone else. And I think that's important, because self-centered focus, when people are very self-centered, they're concerned just with themselves, it's very difficult for them to experience any kind of empathy. And the second component was actually the process and the content of what happens during empathy. And it's the ability to identify what someone else is thinking and feeling, and to respond to their thoughts and feelings in an appropriate way. And empathy is normally, it's accepted that they can fall into two different groups. The cognitive type of empathy, which is the recognition of distress in someone else, and the more affective component is how do you react once you have recognized that somebody is in distress. It's your reaction to it. And there is research to suggest that affective empathy in particular is largely genetically determined, whereas cognitive empathy is more environmentally influenced, so getting the kind of recognition. But there is research among animals and among infants that does suggest that there is recognition in distress early on, and it looks like it's instinctive. So you can get if a young child is in the presence of somebody who is clearly distressed, there is a reaction in the baby, and the same in animals. So I'm not convinced that you necessarily need recognition. Recognition may be instinctive. It may not be a very clearly thought out process. It may be that you're reacting instinctively to the distress of someone else, and there is a recognition at a low level rather than actually a kind of a thought process. Now, moving on to the function of empathy, it's normally considered that it helps to form and maintain relationships. So the basic function is to create relationships, bonding, if you like. And it motivates kind of social, pro-social and moral behavior. And if you don't have empathy, it may create problems. I was thinking in certain professions, for instance, if you're a clinician, you need a certain amount of empathy. But if you've got empathy, too much empathy, it may actually impair the way that you work. If you're a dentist, for instance, and you've got too much empathy, you may not want to create sufficient pain to get rid of the decay. So in actual fact, I think it's important to recall that empathy, influences behavior, and sometimes you need to cause pain to get people better. So empathy is an interesting concept in us as clinicians. In terms of diagnosis associated with empathy, psychopathy, clearly there is a link with psychopathy. You also got antisocial personality disorder that overlaps with psychopathy, but it's not the same. Borderline personality disorder, narcissistic personality disorder. I mean, that sort of makes sense. Classic autism, Asperger's and schizophrenia. And sometimes this lack of empathy can be very extreme. I've certainly seen people who were completely lacking in empathy and being very sadistic and actually getting pleasure in causing distress in others, associated with antisocial personality disorder and an extremely high level of narcissism. So I think when you have the combination of antisocial personality disorder and then narcissism, it's a bad combination in relation to empathy. So the Vera, the first I learned about the Vera is that I was at a conference. Susie Young was at the conference, Jessica Brumham, and Susie Young and Jessica were discussing a way of developing a measure of empathy. And they invited me to join the discussion about developing this tool, because there was the kind of absence of a victim-specific empathy scales that was suitable for offenders. So that's the way it developed. It was about 10 years ago. It took from time we first discussed it, and Susie was leading in it. The Vera developed and was published. And the first Vera actually required people to listen to a radio broadcast between a male interviewer and a female victim. And there were 5 different trigger events. So basically they had to listen to radio programs about somebody involved, listening to a woman involved in a road traffic accident, arson, fire, and assault, child sexual abuse, and rape. People were asked to rate actually how they felt after watching that particular radio program. They were listening to it and asked to rate how they reacted to it, and also how they thought the person who was the victim was actually acting or reacting to it. In actual fact, these were not genuine victims in the radio program. I mean, these were people who were acting in terms of these different vignettes. So the Vera 2 developed because we recognized that the radio vignettes were limited, and we had discussions with patients. In actual fact, in developing the Vera 2, there was a discussion with patients about what they thought of these measures, and it became evident that it was important to have a kind of a video, a picture. You get more information. You can see the person rather than hearing the person being distressed. You can actually see the person and see how the person is describing things and how distressed the person looks. So that's the way the Vera 2 developed, was actually having actresses, and these were professional actresses. In actual fact, we went actually to vet them, to make sure that we selected the best actresses, and there were different actresses in different scenarios. So that's the way it developed. The other beauty of the Vera 2 is that it was a computerized version. So in actual fact, you got the vignette, and then you had to fill in a couple of questionnaires, and in actual fact, you couldn't go on to the second scenario or vignette till you'd actually completed all the questionnaires. So there is no missing data in it, which is actually very good. And actually what happened is that we changed one of the vignettes, who actually, the arson one, because it was a bit ambivalent in the radio program whether it was arson or just fire, just an accidental fire. So we made it into a crime-related scenario in the Vera 2. So after watching each video, the participants are asked to complete these 2 questionnaires, how they felt whilst watching the video, affective empathy, how they thought the woman felt, cognitive empathy, And they were rating how they felt and how the other person felt on 8 negative emotions, feelings of distress. Whether they were worried, sad, upset inside, distressed, disturbed, angry, disgusted, frightened. And they were rating it on a scale from 0, not at all, to 4, very much. So I talked about the computer program that prevented people moving on without completing it all. And then one was able to actually score each vignette and get a score for how the person responded on that vignette. And also you could average it out across the different vignettes. So you can look at how the individual responded to, for instance, rape, in contrast to another vignette, or you can average it out to get a kind of a global measure of empathy. So the validations, I want to talk about this validation that we did, and actually it was done in Broadmoor, and it aimed to validate the VERA 2 among mentally disordered offenders. And what happened is that there were 55 patients, and 40% of them had a primary diagnosis of severe mental illness, and 60% had a primary diagnosis of severe personality disorder. Now, we did not hypothesize that one group should have more or less empathy than the other group, because if you look at people with a diagnosis of psychopathy and people with a diagnosis of schizophrenia, and there may obviously be some overlap, but if you look at these two groups, both of them, in terms of the literature, have some deficiency in terms of empathy. So it's difficult to say that one group should have less empathy than the other. And in fact, we found there was no significant difference between the psychopathy diagnosis group and the schizophrenia diagnosis group. So, and then we were looking at trying to validate this by correlating the empathy measures with traits, antisocial personality traits, which we use the EPQ psychotism scale, the Morsley Violence Questionnaire. And the Morsley Violence Questionnaire has got two different aspects of violent cognitions. One is called machismo, where in actual fact people are aggressive because they want to be seen as strong. They don't want somebody to be telling them what to do, and they are basically taking a kind of a position where violence is the way of actually influencing people's behavior. Then there is the other aspect, which is kind of acceptance of violence, which actually is different. They correlate about 0.5, these two subscales, but acceptance of violence is basically saying that violence is a way of life. You have to accept it as a way of life. It can be quite enjoyable at times, and in actual fact viewing it in a positive way as no big deal. So there is a difference between these. In actual fact, in research, there is a difference between these two subscales of the Morsley Violence Questionnaire, and we found a difference in this study. There was the global empathy, and we used the Eysenck empathy scale. And then what we wanted to look at was remorse. In actual fact, does empathy, tested in relation to different vignettes, correlate with the way the participant endorses or reports feeling remorse for their index offence? And that's quite actually important, you know, how people are responding or in terms of remorse in relation to their own crime. Does that actually give an indication of how they might respond to the vignettes? And they used my blame attribution imagery. It has a scale of remorse for offence. It's actually got 3 components. Blaming the offence on mental factors, blaming the offence on external factors like provocation, and then has a remorse scale which we used. We administered the whole scale, but we only used the remorse one in this study. We also looked at sex offenders, looking at, and I'll explain that in a little while, about distinguishing between people who have a history of sex offending and with other people who don't have a history of sex offending. So the hypotheses were, the three: the antisocial personality traits and violent cognitions will be negatively associated with both cognitive and affective empathy, whereas remorse for the index offence will be positively correlated with empathy. And secondly, that the Vera-2 affective empathy scale be positively correlated with the general affective empathy questionnaire. This is the ISINC measure. This is a general measure of affective empathy. And thirdly, that participants with a history of sexual offence in their record will have higher Vera empathy scores than those without such a record. If you look at the empathy measures correlations with the other tests, you can actually see that the measures correlate generally better with affective empathy than with cognitive empathy. And you can see that the hypotheses are actually supported. You can see that there, because you can see if you take, for instance, psychoticism, it correlates both with cognitive empathy and affective empathy, antisocial personality traits. If you look at the ISINC empathy scale, theoretically it's only related to affective empathy, it doesn't measure cognitive empathy, and you can see that's borne out. Machismo actually correlates with both the scores, the empathy scores, but slightly more with the affective one. But you can see the acceptance of violence has a higher correlation than machismo in relation to both cognitive and affective empathy. And the remorse for their index offence, the amount of remorse they were expressing, actually correlated both with cognitive and affective empathy. You can see the largest correlation, 0.3, which is a large effect size, was in relation to affective empathy. So these are actually quite sound findings. Now, differences in empathy between sex offenders and other offenders, and what we did was to look through the records about whether there was a history of sexual offending in the records of the patients or not, and we split them into these groups. Now, in terms of, you can see that in actual fact, if you look at the different vignettes, you can see that the largest difference was actually in relation to cognitive empathy and not affective empathy. So in actual fact, if you are looking at sex offenders and non-sex offenders, other offenders, you can see that cognitive empathy discriminated better between them than affective empathy. And the largest was in relation to child sexual abuse, which is a large effect size of over 1. And even the rape is 0.83, it's a large effect size, and total empathy 0.82. So the other scores were quite low. There was a bizarre finding in relation to violent assault, in the sense that affective empathy had a moderate effect size in relation to, in actual fact, it's a moderate effect size in relation to violent assault, whereas cognitive empathy didn't. And we don't really understand why that should be the case. What is needed is a much larger group of sex offenders and comparing them with other offenders, because the samples are quite small, but they do demonstrate, which has been shown in relation to my blame attribution imagery. We've done a number of studies to show that sex offenders consistently report greater remorse and also shame, because there's a combination, there's a difference between feeling ashamed and feeling guilty. So you can feel ashamed of what you've done, you can also feel guilty about what you've done, and the difference is with feelings of shame, it shuts people up because people don't want to talk because they feel ashamed, whereas guilt makes them want to talk. So there's a kind of a conflict there. But so I think it's worth looking at differences in terms of empathy and what it actually means. Why should sex offenders have more remorse than other offenders? Is it probably because the offending is seen as more shameful and they report more remorse about that? Now, conclusions. All three hypotheses supporting, basically showing that this is a robust construct validity of the Vera 2. Antisocial personality traits and violent cognitions and remorse for the index offence were correlated with both cognitive and affective empathy. The correlations were significantly higher for affective than cognitive empathy, with the exception of acceptance of violence. Acceptance of violence is a powerful predictor of both cognitive and affective empathy. The finding that reported remorse for the index offence was significantly correlated with both Vera 2, cognitive and affective, whose content had nothing to do with their index offence, actually has significance, and actually it does suggest that perhaps, this tool can be used, and actually, fact, it can be incorporated. The findings can be incorporated into treatment. Interestingly enough, and I think that's important, that the Vera scales did not correlate with IQ, nor did they correlate with social desirability, because often with self-report measures on questionnaires, people have a tendency to report things in a socially desirable fashion. Now, the Vera is still in its infancy in terms of the scenarios all involve women alleged victims who are actresses, and the actual people being tested are all men. What would be really interesting is to also use this tool on female offenders, but that hasn't been done yet, but that's another way of actually doing research. The other thing that actually I'm very interested in personally, and that is empathy in relation to ADHD, because we know that empathy is low in people with Asperger's and autism, but we don't know about ADHD. And I'm interested to see if, for instance, medicating people with ADHD, whether that affects the level of empathy. Because if people are symptomatic for ADHD and they are very focused on their symptoms, they may be so self-focused because of the distress and the symptoms that they're not able to really take other people's perspective. So if you medicate them, that in actual fact, so the symptoms are reduced, do you actually change the level of empathy? I mean, that's just an idea in terms of research. So I've just finished now, and I'm very happy to take questions. I think I'm on time. Thank you.